So I want to talk about a little bit about drivers for shared decision making and our experience of our daily engagement and involvement with patients and caregivers who are living with a brain tumor. There's not a story to be told without the patient, and the value the patient brings into the consulting room far exceeds that as the purely clinical. So they bring value to stratified medicine. There's the familiar nature of genetic information, and also the need for intra-family communication. There's also the personal utility of genetic information and the public recognition and expectation that increasingly now we're taking personal responsibility for our health. I think nearly everybody has some form of wearable where they're monitoring deviations in trends from what's going on in their lives. And also we bring, of course, our unique cultural and social perspectives. And that's often what we spend a lot of time eliciting when we're talking to patients and caregivers about what's important to them, what matters to them most. The drivers to establish shared decision making include unwarranted variation in clinical practice. We know too that we have very often a culturally based medical decision ethos that's involved from a paternalistic model. So when we want your opinion, we'll give it to you. And also, you know, there is a tendency amongst the patient and the caregiver that when they present with a problem, they'll just go to a paid professional to get them to fix their problem, which of course isn't always fixable, never more so than when you have a brain tumor. But just reiterating too what Helen has said, that research shows that patients who are supported in shared decision making, so navigated patients, attribute knowledge and understanding of diagnosis and treatment to feeling better able to cope. They're less distressed due to being better informed. They feel prepared and use question lists. They're broader, but they have broader but also more focused consultations, and they manage transition points better. So I'm going to just exemplify this with Andrew, who's a patient we're currently supporting. Andrew has been recently diagnosed with a glioblastoma. He's at the prime of his life, but this has just overwhelmed him. He's recently divorced. He has shared care of his children, but he doesn't have the capacity or the resources to be able to host them at weekends when he's supposed to have them because he's in rented accommodation. He's lost his driving license and his job, so he can't afford to pay child maintenance. So the relationship with his ex-wife is one of really fueled with anger because she feels very let down. And he's remote from his family, from his parents and his brother, who live a long way away. So his challenges are huge. He has the disease trajectory. He's living with a high symptom burden, including epilepsy. He knows that he's got progressive and neurocognitive and neurological decline. And with this also the pressure of teleological time, the sense that time is running out. He has a lack of support. There's nobody really in his team around him that he can identify who can help him. He's a very proud man. He doesn't see any point in going to see the GP because A, he struggles to get an appointment with them, but also he'll only have a 10-minute time slot. So he's living with huge uncertainty. He's in a permanently heightened emotional state. And every time he has a discussion with anybody in his clinical team, it's always focused on treatment. And there isn't much space for Andrew to talk about what matters to him on this clinical pathway, let alone start to have a conversation with him about shared decision making, because at the moment he's so overwhelmed, he can't really begin to think about what's best. The closest he will get is probably sitting down with a clinical nurse specialist who might want to go through a patient concern inventory with him. But all this is doing is reinforcing to him what he can no longer do. So that's the micro. If we then look at the macro, this is some concordance work that came out of Cambridge University, which really reflects discordance. Patients presenting for initial assessment in the neurosurgical oncology clinic were asked to complete the QLQ-C30 and the BN20 brain cancer module questionnaires prior to the appointment. And what they wanted to talk about were fatigue and future uncertainty. Those were the two top challenges that they were worried about. Whereas the clinicians, the blue spikes, wanted to talk about visual disorder, motor dysfunction, communication deficit, headaches and seizures, all the things that you could probably write a prescription for or do some referral to some other therapist like speech and language or a pain clinic or an epilepsy nurse specialist. So this just goes again to show that there is discordance between what patients want to discuss in clinic and what consultants and other doctors are happy talking about. So this is about how do we close this gap. And I think as patients and caregivers, our experience is that they're very keen to grow the conversation where they are actually taking more control over their own health state. And this is where the role of shared decision making comes into play. So the goal is to ensure that every person who needs and wants it has access to the type of discourse that is needed for shared decision making. And it's not one that just happens ad hoc or by random or by serendipity. It needs preparation. This is the zeitgeist because it drives involvement in care, it improves quality of life, it creates better outcomes, and also there's a health economic argument too. It will save money. But to deliver this, we do need prepared patients. Patients need to go in knowing that things will be asked of them and that they too have expectations that they must meet. We need trained teams. Certainly some research shows that clinicians think they're doing shared decision making, but actually they're not. And we need supportive systems. So from the top down, we need to mandate shared decision making. And I was really pleased to see in the UK, well in England on June the 17th, we had the NICE shared decision making guidelines published. We need the technology, the tools, and we need the cultural changes to be able to do this. And from the bottom up, I think patients and caregivers have a role to play in changing the conversations that are happening in consulting rooms, whether they're face-to-face or on Zoom. So what we do at Brains Trust is we use coaching, and we know that this creates shifts. It moves people from being out of control to taking charge. We know too that it creates resourcefulness, that caregivers, for example, are better able to use support more effectively because they know where the focus is needed. And it creates resilience, that people are better able to face things. And for us as a charity, it gives us a framework too, because it means we get closer to our users. It creates a more meaningful dialogue for us at every touch point, which creates clarity and purpose for the patient and the caregivers. So we know what the focus of our coaching conversations are going to be in that particular moment in time. And it creates a structured framework within which we can work. So I know when I'm working with my support specialists what the quality of the conversations is happening when they're picking up the phone or whether they're typing an email to the people that they're supporting. And also we use a lot of questions. So we ask more questions probably than are answered. And we find this is the easiest way to break the ladder of inference. So the assumptions that we instantly make, which we can't help ourselves making. So we ask lots of questions about what people are thinking so that we can test our assumptions as well. But we always avoid why questions. It puts people on the defensive. We use a lot of what and how questions, unless it stems from genuine curiosity. So I wonder why. And we find that questions open the door to dialogue, creativity, and they also help break through with thinking. They lead to movement, they generate insights, and they ignite change. But in the Western culture, we don't always ask the right questions because we tend to focus on the right answer, the answer that we want to hear, and we listen to the chatter going on in our heads rather than the right question. Between our deep attachment to having an answer, any answer, and wanting to fix a problem, and our anxiety about not knowing, we've thwarted our collective capacity for deep creativity and fresh perspectives. And one of the simple things you can do is silence the chatter in your head and be ready to admit that actually maybe you don't know the answer, but working together, you can find an answer that's appropriate for that patient. So even asking simple questions such as what does this all mean for you? Or what haven't we thought of in the space that we've had that could make a difference, can create significant shift and change within a person. So powerful questions will generate curiosity. They'll stimulate thoughtful reflection. They'll lead to reflective conversation. They surface underlying assumptions. They might channel intention and focus inquiry. They stay with the patient and their caregiver, and they'll travel well. They're a question that they will come back to over time. They'll touch deep meaning, maybe often creating an emotional response where you have touched a nerve, and emotion is always good, and they'll evoke more questions. So in our conversations, the basic tool we will use is the GROW model, where You might spend 60% of the conversation eliciting what would be a good goal. How would you feel that this has been time well spent today? So what would be a good goal, a good outcome for this conversation? What's the reality you're dealing with at the moment? Forget everything else, put everything else aside. Just describe the reality to me. And then, so what are your options? And when you've elicited from the patient and the caregiver what their options are, you would then focus on one and really unpack that. So what do you need to be able to achieve this? Who's in your team? Who can help you? What's missing from this that's going to stop you achieving your goal? And then you summarize with, well, so what's your will? What are you going to take away from today's session? So the non-negotiables for us, I think we'd love to see a focus on maintenance of wellness rather than a treatment of illness. So coming back to Andrew, so what is working in your life at the moment? What's going well? Keeping the person very much at the heart of it. So giving the right information at the right time, and that can be very challenging when you have a caregiver who maybe wants to know more information up front because they know then what to expect, what they're up against, whereas often the patient, particularly when it's with a high-grade glioma, doesn't want to know all of that information. How do you tease that out? They want clear expectations. They want a more equal relationship with their doctor, with more honest discussions sooner. And we find that through our research, patients have said they want to know how to get what they want out of the discussion so that they can feel in control. And they also want to know how to deal with death and dying. And we believe, you know, all of these could be facilitated at a quality of life MDT, where you have a wraparound supportive service. But to need that, to get there, we are going to need prepared patients, trained teams, and supportive systems. I've highlighted Cochrane. Cochrane has already been mentioned, but there's some really good evidence-based resources there on their website. And I think for me, the end of this is that you cannot not communicate. So show a curiosity about your patients. Politeness is good, yes, but curiosity is better. Value real life experience with a focus on quality of life. And always think, are we asking the right questions from data, from any or all of data, to get the best outcome? And I think if, you know, I was going to say the one thing you could take away from this today is ask just one question, which is a question we ask day in, day out. And that is, what are you struggling with the most at this moment in time? And don't be afraid of the answer. It's not your role to fix it, but just asking the question is patient-centered care, because it will, I promise you, elicit unmet needs. It shows empathy and understanding that you're listening and that you'll care. And that's all Andrew needs to be asked at this moment in time, is what matters to him, because eliciting from Andrew what matters to him, what his values are, his context, his appetite for risk would be a transformative conversation for him and for his clinical team. It would place him as a co-pilot in his care. Trust levels would be high. He's more likely then to engage in shared decision-making conversations in the future, because he'd be regarded as an asset in his own care with his own sense of resourcefulness and range of capabilities. So we need to combine a person-centered process embedded in shared decision-making so that quality of life and care become just as much as a rich theme in research as the research for a cure. And this is what matters to Andrew. So thank you for inviting me to talk today, and thank you for listening to me.